Stenkosa. I'm a clinical oncologist from Oslo, Norway.
Good morning. My name is Marianne van der Schuur. I have a background in
Frank
nutrition and
webinar
dietetics,
on
and I'm from
nutrition in
Nijmegen, the Netherlands.
We are live streaming. We're happy to have Germany. All of you
My
online.
name is
Stenkosa. As I said, the topic today is nutrition in oncology, Oslo, Norway, and we are Germany. My name is Stenkosa. I'm a clinical oncologist from Oslo, Norway.
Good morning. My name is Marianne van der Schuur. I have a background in nutrition and dietetics, and I'm from Nijmegen, the Netherlands.
We're happy to have all of you online. As I said, the topic today is nutrition in oncology, and we are actually following up a conference which was organized earlier this year, Frank 2019. So I will give you an update on trends and new insights from this Frank conference, and Marianne will give you a patient journey, including nutritional challenges in older cancer patients.
Well, today is a live webinar, so we would really invite you to send in your questions that we will be able to discuss later on, and also we will ask you some polling questions during our presentations. In a few seconds, we will start with the presentation by Stein on trends and new insights of Frank 2019.
Thank you, Marianne. And as we already said, I will cover the topic trends and new insights from Frank 2019. And I hope that you will be interactively following us. Here are my disclosure slide. Frank 2019 was organized, as I said previously this year, with 10 faculty members from various countries, from France, from Germany, from UK, from Italy, from Norway, and us two chairing it from the Netherlands and Norway. We had more than 150 delegates from 29 different countries. So what I will try to cover with you today is who is the patient in front of you, and why is it important to define and classify the patients to understand what are the patient's problems and challenges and how can we help the patients. What is the prevalence of nutritional issues, and what about multimodal therapy? How does it work? We will also cover the topic patient-centered care, and also talk about, is it a challenge to implement nutritional care into clinical practice? And I will round it up with some take-home messages. First to you. How is the nutrition assessment and treatment integrated in the cancer care pathways? So you have 4 options. 1, classify the patients routinely. Nutritional issues should be considered from the time of the cancer diagnosis. Nutrition is an integral part of early palliative care to improve quality of life in cancer patients, or all of the above. So please think about it and give your answer, and we will come back to it after my presentation. So why is a cancer patient at nutritional risk? Well, the pathophysiology is extremely complicated. This picture just gives you an overview of one of the most important pathophysiology drivers, that is systemic inflammation. And systemic inflammation can give rise to muscle loss, muscle wasting, sarcopenia. It will affect the liver metabolisms, which will have a major effect on nutritional issues. And it also will affect fat use and depletion. And at the same time, the cancer itself, the tumor, gives signals to the central nervous system, which again gives rise to anorexia. So this is a very simple picture, but we will go into more details. But keep this in mind, the complexity and the systemic inflammation. So who are the patients? It has been discussed for decades. And this is a classification system which was published some years ago, an international group chaired by Ken Fearon. In this group, we decided to group the patients into three subclasses: pre-cachexia, cachexia, and refractory cachexia. And as you see from this slide, we use weight loss as a classifier, we use anorexia as a classifier, and we use metabolism as a classifier. And the whole idea here is that if patient is starting on a cachexia trajectory, you need to come up with a diagnosis as early as possible and do the intervention as early as possible, which we will come back to and cover during my talk and also during Marianne's talk. And then the whole idea behind classification and behind trying to understand the patient is you need to do it routinely. It needs to come into the classification of the patient, the diagnostic workup, in addition to the traditional TNM classification of the patient. So we have to start with the screening. Who are the patients at risk? Then we need to follow it up by systematic assessment in more details. Then we need to put that into the diagnostic process. And then we need to get that knowledge into the multidisciplinary team meeting. So when patients are receiving anti-cancer treatment, they should also receive symptom control, nutritional care, etc. So that's an important take-home message from the seminar. Well, we know that the prevalence of cachexia and weight loss, it varies considerably between tumor sites. As you see here, is much more prevalent in pancreatic cancer than in prostate cancer, than in breast cancer. Lung cancer is also very prevalent. So these data shows you that there are large individual variations between patients depending upon what type of diagnosis you have. So, and it was also shown very clearly in one presentation that sarcopenia, which means muscle loss, is an important predictor for outcome after surgery. This slide shows data from gastrectomy for gastric cancer, but we know that from surgery in general, patients who are in bad conditions, bad nutritional risk, high risk for nutritional depletion after surgery or during surgery, they should receive nutritional therapy before. And the same goes for symptom control in general. So again, it's important to understand the patient before you start the anti-cancer treatment. So, and then we have some further important trends influencing nutritional support in cancer patients. Prehabilitation concept, which I already covered. Patients' clinical complexity is increasing with comorbidity. The more and more elderly populations, they are having more comorbidity, which we need to take into considerations, such as diabetes, obesity, chronic kidney disease, cardiovascular disease, etc. So what do cancer patients with relapse tell us? What do they expect from us? Well, patients, when they get a cancer diagnosis, they tell us that they want to live as long and as good as possible. And we need to realize that patient-centered care, palliative care, supportive care should be an integrated part of the cancer care pathways. So how do we think when we are talking about how to intervene with regard to nutritional support? Well, we need to think about the team. We need to have early integration. We need to have awareness. We have to have optimal nutritional support. We need to have exercise support, which I will come back to in a couple of minutes. We need to think about the effect of anti-inflammatory drugs. And we need to think about how we best can support the patient and the family together. So, and during the Frank seminar, it was also a session on the effect and the place for pharmacological targeting agents in order to prevent cachexia or to treat sarcopenia. To sum it up, pharmacological targeting agents are mainly used to decrease systemic inflammation increase muscle mass, and stimulate appetite. We use corticosteroids and progestins for short-time relief of appetite loss or early satiety in clinical practice. But to use corticosteroids over time is not very good for the patients. We have some promising new drugs for appetite stimulation, which is in process and which is now evaluated in clinical studies. Drugs alone will probably not be enough, but necessary to combine with nutritional interventions and physical activity. Exercise is important. Cachexia accelerates loss of function. Exercise is a core component of the multimodal therapy approach, and it may also improve pain control and function, which is shown in several clinical studies. And a recent systematic review shows an improvement in depression and physical support and physical function, supporting the concept of a multimodal therapy, including exercise. So understanding and implementation of patient-centered care is central. Here you see on this slide on the left side 2 figures. You see the old way of thinking that you should have palliative and supportive care coming late in disease trajectory. The take-home message today is that it should be integrated. We need patient-centered care, we need supportive care, we need nutritional care early in the disease trajectory, already from the point of time where patients are getting his or her cancer diagnosis. So it is a time for a change or perspective. So the issue is how to combine the 2 paradigms, the tumor-directed approach, the anti-cancer treatment, and the patient-centered approach, the host-directed approach. And here nutritional care is central, as well as symptom management. So we're talking about a patient-centered care umbrella, and here you see it's much more than exercise, it's more than nutrition, it's more than supportive care. We need to see how we can combine this patient-centered approach when we are understanding the patients and when we are treating our patients during cancer therapy. So how can we implement this into clinical practice? Well, we have some challenges which we also need to take into consideration, because the healthcare systems, either they are private or public healthcare systems, they are organized in silos. So we need to see how can we break through these silos. And what we discussed during the Frank seminar was how could we use the cancer care pathways, standardized care pathways, a plan to help the patients to travel through these silos. So a good plan is what we were advocating for. In order to implement it into clinical practice, we really need to have a plan. So here are 4 steps I think you need to consider. One is awareness. The physician and the other healthcare providers must be aware of the evidence. So, for example, nutritional treatment, nutritional support, it works early and also later in the disease trajectory. It needs to be customized to the patients. Second is agreement. The physician and the healthcare providers must agree with the evidence. Thirdly, adaptation. The physician must treat his or her patients according to the evidence, which means that it's not enough to write the guidelines, you need to put the guidelines into action. And adherence. The physicians must adhere to the evidence over a period of time. So it means that you should probably have some sort of system where you are evaluating whether the care pathways are implemented into routine clinical practice. So how to implement nutritional care into cancer care pathways as of today and in the future? Well, as I said, we need to classify the patients. We should have a common classification systems, and there are some good systems which also will be illustrated in Marianne's talk shortly. We need to have innovative patient-centered care with nutritional care as an integrated part of the care pathways. So it means that we need to plan the patient-centered care, the nutritional care, the diagnosis of the patients together with the classification and the treatment of the patients with the cancer. So the TNM classification together with the nutritional classification. assured to have the right competence at the right place at the right time. So it means that, for example, that nurses should have basic training in nutritional care. The same with oncologists, they should have basic training. So improve the level of evidence, conclusive clinical trials. We also need more research. We have the ESPEN guidelines. They call for screening, they call for systematic assessment, and they have a very clear strategy on how to step up the nutritional therapy from oral to enteral to parenteral. So the take-home messages from the Frank conference was, well, barriers still exist to preventing implementation of nutritional therapy in routine clinical practice. So we need to work together. Secondly, nutrition is an integral part of early palliative care to improve quality of life in cancer patients, which is well shown. Thirdly, nutritional care is an integrated part of cancer care pathways. We need to get it into the multidisciplinary teams. Standardized care pathways connect different levels of care to provide the varying needs for care at each individual patient. So I hope that after this web seminar today that you will get some new ideas and we can work together on how to integrate nutritional care into the cancer care pathways. Thanks a lot.
Thank you, Stein. This was an excellent presentation. We'll come back to the results of the poll in a few seconds. Well, here's the results of the poll. You have answered the questions, and the vast majority of you have answered that all of the above steps should be taken to secure nutrition therapy. Please, could you comment on this, Stein?
Yeah, I'm happy to hear that, or to see that almost 90% had a very comprehensive approach to how to improve nutritional care. And I'm happy also to see that everyone said that to classify and or to nutritional issues to be considered from the time of the cancer diagnosis. That's not enough. You have to do the whole package. So I'm happy to see that.
Good. So we also received some questions from you. You sent in some questions. One of the first questions that we got is from the Russian Federation. So, Stein, how can nutritional care pathways be integrated into cancer care pathways?
That's a very good question. I believe that we need to start to work together. For example, I'm active in European Society for Medical Oncology. So when we are making guidelines, for example, for pancreatic cancer, we need also to include nutritional care into these pathways.
Is this what is happening in your institution?
Unfortunately, not all the time.
Okay.
Because we are also operating in silos. Mm-hmm. You have oncology silos, you have palliative care silos, you have supportive care silos, you have nutritional care silos. So I believe that we need to break down these silos when we are also developing the guidelines and when we are developing the care pathways. Okay,
so what you're saying is give nutrition a fixed place within the cancer care pathway.
Yeah.
Yeah, I fully agree with that, yeah. So I think we're done with the questions. And we can start the next session.
Okay. So I will hand over to you, Marianne.
Yep.
And you will have your talk, and I'll give you here so you can show your slides.
Okay. So I'll wait for the jingle. So good morning to all of you. I I will give a presentation of a case discussion, an older patient with cancer, and follow him during his patient journey. My disclosures are presented on this slide. So the patient that I'm presenting is Mr. Williams. He's 70-year-old. He has always been healthy, and he presents at the outpatient clinic with swallowing problems. He is diagnosed with cancer of the esophagus, and otherwise he has no medical history. Since he's 70 years or older, we screen him with the geriatric age screening tool, a simple tool to determine which geriatric patient may be at risk for being frail. It consists of 8 simple questions, takes less than 5 minutes, and the tool is predictive for chemotherapy, toxicity, and survival. So the 8 questions you can see here on the screen, and Mr. Williams, he scores positive on 3 of the 8 questions. Diminished food intake, weight loss, and low BMI. That's why we need to further assess his nutritional status. To start with his weight, he has lost weight 8% from his pre-illness body weight and 6% over the last 6 months. He now weighs 71.4 kilos. So I just want you to think of the following. Do you think that based on weight only your patient consider to be malnourished? Well, let's dive into this. The recent GLIM criteria of malnutrition define a patient malnourished when, after a positive screening, he fulfills at least one of the phenotypic criteria and one of the etiologic criteria. The phenotypic criteria are weight loss, low body mass index, and reduced muscle mass, and the etiologic criteria are reduced food intake and inflammation. We know that he has lost more than 5% within the last 6 months. But what about the other criteria? Let's have a look at a further nutritional assessment. His height is 1 meter and 88 centimeters, which ends up with of BMI of 20.2. And his dietary intake is assessed. He can only drink liquid foods, but no solid foods, and his intake is around 500 kilocalories per day. We do a nutritional assessment and assess his fat-free mass index by bioelectrical impedance, and his fat-free mass index ends up at 17.8 kilogram per square meter. The reference value for this is 17. He has a very good hand grip strength, and he does not have any inflammation. His CRP is 4 milligrams per liter. So coming back to the diagnostic criteria, he displays weight loss, he displays a low body mass index, and he displays a reduced food intake. So he fulfills one of the phenotypic criteria and one of the etiologic criteria, which classifies him as being malnourished. So what kind of malnutrition does he have then? Then we go back into the literature again, and in 2017, this decision tree was proposed, and you can be, if you are malnourished, you can be either malnourished with inflammation. The extreme form of that one is cancer cachexia. You can have disease-related malnutrition without inflammation, or you can have malnutrition without underlying disease. Well, we have seen that he does not have inflammation, so we would classify him as having disease-related malnutrition without inflammation. The next question is, does he have sarcopenia? To define a patient with sarcopenia, we follow the following steps, published late 2018. First, we do sarcopenia screening with the SARC-F, and then in the diagnostic procedure, we first assess muscle strength or function. Well, we have seen that his grip strength is very, very good. So based on this first step of sarcopenia assessment, we can tell that he does not have sarcopenia. So in summary, we have a patient who presents with disease-related malnutrition without inflammation, but not with cachexia and not with sarcopenia. So then, is he in need of nutritional support? I think we all agree that he is. But I would like to ask you to fill in your polling question. Would you consider to start tube feeding right from the diagnosis? You can either choose yes, no, or you're not sure yet. We'll come back to this later. So what kind of nutritional advice do we want to give him? First, we need to determine his energy and protein needs. Following the ESPEN guidelines, energy needs are between 25 and 30 kilocalories per day, and protein needs are at least 1 gram per kilo per day, but for older adults, at least 1.2 grams per kilo per day. Vitamins and minerals are to be given following the recommended daily allowances. Further, during treatment, we want to advise a patient to ensure an adequate nutritional intake and to maintain physically active. If oral intake is inadequate, then we should start enteral nutrition, and if that is inadequate, we could even consider parenteral nutrition. During mucositis or tube feeding or mucositis or obstruction, tube feeding is advised. So, given his nutrition assessment parameters, we calculated his energy requirement. We used the Harrison-Benedict equation in our hospital. But whether you use the Harrison-Benedict equation or the 25 to 30 kilocalories per kilo, the estimated requirements are around 2,000 kilocalories per day. Protein requirements based on 1.2 grams of protein per kilo are at least 85 grams per day. He has obstruction, he cannot eat, so we start tube feeding right away. 1.5 liter high protein feed, 1 liter overnight and 500 milliliters during the afternoon. Since he has an obstruction high in the esophagus, a nasogastric tube is the preferred way of providing the nutrition. He receives neoadjuvant therapy according to the CROSS protocol for 6 weeks. And during these 6 weeks, he is closely supervised by the dietitian. He starts losing weight, but then that is adjusted and corrected. And after 6 weeks, he ends up with a stable weight of 72 kilos. 72 kilos. He's then prepared for surgery, and we decide to continue tube feeding before surgery. Although he has his oral intake is improving, he can eat a bit, he still needs to be optimally fed before surgery, and the tube feeding will help him to keep fit as good as possible. We know that patients who do not eat well have a higher risk of mortality after surgery, so that is why there is a clear indication for nutritional therapy before surgery. He is expected to eat poorly during a certain period around surgery. So the surgical procedure is Ivor-Lewis procedure, and the part of the esophagus and part of the stomach is resected, and there's a gastric pull-up into the thorax. So then, how would you preferably start nutrition post-operatively? That can be by mouth, it can be enteral by jejunostomy, or even parenteral, full or supplemental. And the ESPEN guidelines say that it's not necessary to stop oral nutrition after surgery, that it should be resumed as soon as possible, adapted to, of course, the possibilities of the patient. So in this patient, the oral diet was restarted on day 1 post-operatively with a liquid diet, including oral nutritional supplements and a solid food from day 5. The patient is not eating that well, and food tasted strange. Unfortunately, and that happens a lot, no jejunostomy or central venous catheter was put in, but it would have been better to do so to be able to support him better. So he's discharged on day 7 post-operatively, eating a normal diet, continuing the oral nutritional supplements, and he has follow-up appointments with the dietitian at regular intervals. In the beginning, he is having some problems. His weight diminishes, his fat-free mass and his hand grip strength decrease. Eating is difficult, and he loses a bit of weight and strength. He eats 6 small meals a day and still uses 3 ONS per day. The dietitian is really supervising him closely. And after 9 months of operation, his weight is stable, but you see an increase in his fat-free mass and an increase in hand grip strength. He feels good, he exercises, he sports, but he does not manage to gain any weight. Muscle mass and muscle strength have increased. So the dietitian and the patients set long-term dietary goals, which are set at maintaining weight, increasing strength, and increasing activity. Reconsidering what we have done, we would advise in general to first, when you have your cancer patient, when you see your cancer patient, you first determine his life expectancy. If he's undergoing active cancer treatment and is expected to live more than 3 months, you screen for nutrition risk. And if a patient is at risk, you should go into a further nutritional assessment. This should be nutritional status, metabolic and functional status, symptoms impacting on nutritional intake, but also other symptoms like pain, dyspnea, psychological and social distress, and medication. This guide, all these items guide your nutritional intervention, and nutritional advice should be adapted to a patient's personal need. Alleviating the symptoms, reaching nutritional goals, and optimally supporting anti-cancer treatment. In a patient who is not at risk, you should rescreen at regular intervals and start your intervention as soon as this is necessary. Of course, this patient was not a candidate for parenteral nutrition because he had a gut that worked. But the ESPEN guidelines recommend parenteral nutrition if enteral nutrition is not fulfilling the needs. This patient was on enteral nutrition for a longer period of time, but if that would not be feasible, well, we would have started parenteral nutrition. And parenteral nutrition could even have been indicated post-operatively when the surgeons forgot to put in a jejunostomy or a central venous catheter. So in summary, we saw a patient with recently diagnosed cancer of the esophagus. He was prepared for chemoradiotherapy and subsequent surgery, and nutrition care was started right from the beginning, so it was integrated in the cancer pathway. It was adapted to treatment and was continued up to 9 months after surgery, which kept him in a optimal or suboptimal condition throughout. So I think I hope to have presented you a nice case patient journey and how we can integrate nutritional care into cancer care.
Thank you, Marianne. Thanks for an excellent presentation. I think you gave a very good example of how oncologists, nutritional experts need to work together and plan together and help the patients to be able to do the anti-cancer treatment. So here we have an answer to the polls. Would you consider to start tube feeding right from the diagnosis? So we remember the patients. 50% said yes, and that's what you did. And 50% more or less disagreed with you.
Yeah.
So what do you think about that?
Yeah. Well, of course, there's more than one way to reach optimal nutritional goals. Mm-hmm. In this case, we started tube feeding right from the beginning because there was an obstruction. He was not eating, and the patient was anticipating neoadjuvant therapy, chemoradiation, which is known to be accompanied with a lot of side effects, and then surgery. So we decided not to first try oral nutritional supplements and make him lose more weight, but to start directly with tube feeding, which is quite aggressive, and which is what we would do in our hospital. But I can imagine that others would say that you should start oral or enteral oral nutrition first. So what would you do?
I think it would vary, and I agree with you. There are two possibilities. As you did it, start up front with tube feeding, or to start with oral supplements first and see how it works. But we know, as you said, that this combined chemotherapy is very big stress to the patients, and they need to be prepared for a large surgery. So I think aggressive nutritional therapy is what we need for these patients. But here we have another question from the Philippines to you, Marianne. Why is sarcopenia relevant in cancer patients?
Well, that's a good question. I shortly talked about sarcopenia. I just used one slide, but we have to consider muscle mass as a very important predictor of cancer-related outcome. There's a lot of literature stating that muscle mass predicts both toxicity and morbidity and even mortality. And sarcopenia is important because more and more cancer patients are obese. And even in the obese patient, you can have a diminished muscle mass. So that's why it's so important to assess muscle mass, which we did in this patient. We assessed both grip strength, so function, and we used bioelectrical impedance to assess muscle mass as a predictive measure for cancer outcomes.
So I wonder, coming back to your patient, you gave what you call aggressive nutritional therapy. Mm-hmm. Did you also give the patient advice or support with physiotherapists to do physical exercise?
He was not directly sent to a physiotherapist, but he was given the advice to do exercise, mostly to do strength exercise because that will help him. But it would be even better to have intensive nutritional therapy and physiotherapy at the same time to prepare him optimal for surgery.
Yeah, so maybe some sort of training program which we should help the patients to start with, because my experience that quite often we need to help the patients to get started.
Yeah. And it's difficult. They don't feel well because of the chemoradiotherapy, but still they should be stimulated to exercise next to nutrition.
Okay. Are there any questions from the audience? Not yet, so we'll
wait for, we will have a little in-between gap, and then we will have 8 minutes to have some open questions and discussion with the audience.
Okay, so we're waiting for your questions.
So we're back, and we're waiting for questions to come in. There's none yet, but that doesn't mean there isn't any. Well, as there's none yet, let's start. How would you I presented a patient with esophageal cancer. Do you have a care path in Norway like we do have in Netherlands with nutrition integrated?
Well, again, we have nutritional care pathways, but as I said, they are not totally integrated into the cancer care pathways. Mm-hmm. So I was thinking when you said that, how much integrated should it be? I hope that it could be fully integrated in the future. Okay. So when you talked about nutritional screening, mm-hmm. I would think in the ideal situation, you have to do the TNM mm-hmm. of the patient, you have to do the physical function classification of the patient, you have to use patient-reported outcome measures to measure all the symptoms, and you have to do a nutritional assessment. Yeah. And that should be done for every single patient, in my mind. Yeah. So a full integration.
Yeah. So we got a question from Thailand. Yeah. It says, well, exercise, it sounds good, but during chemotherapy, we know that it's difficult for the patient. How do we integrate exercise into the treatment pathway? And if the patient cannot exercise, how do we prevent him from becoming sarcopenic?
Yeah, that's a very good question. We are actually running a randomized study right now, the so-called MENAC study, which is a multi-model intervention study. It's a multi-center study run in different countries in Europe and in North America. And in this study, patients are getting nutritional support, they are getting anti-inflammatory treatment, and they are also receiving guidance to exercise. And our experience is that you need to put it into a system, you need to advise the patient, you need to follow it up routinely, and it needs to be simple. So patients can do it at home, but they need to be followed up.
Okay. Yeah.
So a plan to the patients, and it's not enough with a weak advice. So Marianne, it's another question from Bangladesh. How many months we can continue the nutritional support? So I don't. This is a very general question. So yeah. maybe we should sort it out a little bit.
Yeah. Well, it's good, and I realize very much that in our country we have a completely different situation from many of the countries that you are from. In our country we have the luck that we can supervise our patients, in this case the patient with cancer of the esophagus, until 1 year after surgery, because we know that they will have problems and they need to adapt their diet until at least a year after surgery. The changes in the anatomy are huge. So that is what is in our care pathway, and we have experienced that the patients want and they need this time. But we are very lucky. So I think in general patients should be followed up until their symptoms are controllable. And, well, another point of discussion is, should we follow them up in the hospital, or should we send them to, for example, home care dietitians, which are much closer to their living situation, and which is much cheaper? That is an evaluation that still has to be developed in our country as well.
Okay, I guess we have one last question.
Yeah, so there's a question from the Philippines. So when would be the best timing and manner to prevent or minimize cancer cachexia?
Well, I think there's pretty good evidence, high level of evidence actually, saying that if you try to prevent or to treat cancer cachexia when it's refractory, it won't help. Then you should have other goals with the treatment. That's best supportive care, and not focusing on physical exercise, etc. So the issue is that you need to diagnose or classify the patients when they are in a pre-cachectic phase and start the treatment early. So it's the same with the cachectic patient as it was with the patient you showed. You need to start early.
Yeah. But then you talk about the pre-cachectic phase. That means with very little weight loss, you already have to be alert.
Correct.
Okay, well, that's a good message to end our seminar, I think. Well, we have enjoyed being here with you, although you were online, but still we had good interaction, and we really liked to share our ideas with you. We would like to remember you to fill out a short online survey, and more news will be coming to you through the website nutritionevents.com. So thank you, Stein. Thank you, audience, and we hope to see you later. Bye-bye.
Thank you. Thanks to everyone. Bye-bye.